Thank you guys so much for taking time out of your evening to be here with us. I know it's always good to get a little bit of education on Medicare planning because it feels like so many things are coming at you at once. So just to introduce myself really quick, my name is Raina Fitzgerald. I'm the Client Services Specialist with CanderPath. I'd love to also introduce our host of the evening, John Kennedy. Yeah. John is a certified financial planner and a partner of CanderPath Financial, and he's been doing Medicare planning for about 13 years now. So just to kick it off, John, I'd love to ask how you originally got started with Medicare planning.
Yeah, thank you so much for that question, Raina. And before I begin, I do want to just give a quick shout out to Oasis in Village Walk, Lake Nona. This is the 6th year, I think. It's the 6th year that we've teamed up with them to with their community efforts to just share this really good information on the A's, B's, C's, and D's of Medicare. We also have a number of our clients joining us tonight, all in different kind of phases of life. Some approaching Medicare, some already on Medicare. But I think for us, wearing my CFP hat, by default, we go financial planning mode. And about 13 years ago, sat down with the client. She said, "John, will you help guide me on this stuff?" And I said, "Well, yeah, sure. I think it's important that your financial planner be able to have these types of conversations with you." But I knew that there was a limitation there. Like I knew what I knew, and I knew what I didn't know. So we sat down with a sales representative for Medicare that I directed her to, and I was honestly just so genuinely disappointed. 45 minutes of a conversation went by, and every question she asked, which was really great questions, kind of turned into the sales pitch of like, this is the product you need. And I'm not here to debate the merit of like whether that product was the right fit for her or not the right fit. But I think, for me, the biggest issue was in that instance, we were focusing on just trying to gather information and figure out what made the most sense. And a lot of times when it comes to Medicare, you get inundated with so much information, and then you go sit down with somebody and they're just selling or pushing a product to you. You really don't know where to look and you don't know who to trust. And so for us, that's kind of how this entire conversation was born. We've been doing this presentation for many years, even before we started doing this with Oasis. And what's cool about it is it's evolved as we've evolved with Medicare as well. A lot of things have changed over the years, but more importantly, tonight you're not getting sold anything. We're not talking products. I'm not going to even mention a company. We're giving you the lay of the land and ultimately the two fundamental choices you have to make when it comes to Medicare and a bunch of other stuff too. So I'd like to lead with a number. Now, if we were all sitting together, I'd make this interactive. We'd do a show of hands. We'd do like a questionnaire and make you guess, what is this number? What does this number mean? It's $662,000 represents the amount that a healthy average couple at the age of 65 will incur on healthcare over the course of their retirement life. So we're talking on average from an actuarial standpoint, approximately 30 years. So it really places the emphasis of importance on making sure if we're going to spend, now maybe we're not going to actually spend 662. This is how much healthcare we're going to cost that we're going to incur. Medicare covers about half of that number. But even if the half of that number is 330,000, if we're going to incur that over a 30-year stretch of time, we better make sure that we understand what we're getting into, what these different types of coverages are, and that we have the best coverage for ourselves. So a couple of quick housekeeping things before I get started. You're going to find out really fast. Actually, there's a bunch of you that are joining this again, like a second or third time. So we appreciate you guys coming and joining with us. That I like QR codes. So I like it. It makes it easy. Open up your phone, open the phone app. And if you scan this QR code in the bottom left-hand side, that's a place where you can ask questions. Of course, you can ask here in the chat as well. There's a chat function that we're going to be monitoring. And at the very end, depending on how much time we have left, we're really going to try to keep it to an hour. We'll answer those Q&As. But if I don't get to it, or if you're watching this video pre-recorded, because we're sharing this out to clients afterwards, you can scan this QR code, type in your name, your email address, ask me the question, and I'll reply within about 24 hours. So we're going to go over a number of things. We're going to talk about what is Medicare, what isn't Medicare. when to enroll, how to avoid penalties, what those penalties are, and then ultimately selecting the optimal coverage. Now, if I just started with what is Medicare, that's a great start. But I actually want to pivot and start with what isn't Medicare. So a lot of times this is like one of the number one questions I get, like, does it cover dental? Does it cover vision? The short answer to that is no, it does not. It also doesn't cover things like optional procedures, cosmetic procedures, and most importantly, I think the emphasis that I want to place here is that it is not a suitable replacement for long-term care. And you're going to find out throughout this presentation why it's not a suitable replacement for long-term care insurance. So what is it? Well, Medicare was created in 1965. It was kind of an add-in with Social Security for folks to have some type of health coverage when they retired. Now, it's very different than Social Security, though. It's not an individual benefit, or rather, it is an individual benefit, unlike Social Security. There's not like a family coverage option. So what you're used to potentially, if you've had a long working career where you work for a company and they cover you on their employer plan, and they cover your spouse and your dependents, your children, that type of thing. Medicare does not work like that. It's a per person benefit. And for most people, and I'll get into this in a moment, there's not typically a monthly premium for Part A. What I have here at the very bottom, though, this is really important. It says additional health insurance may be required. Well, I'd actually like to say we cross that out and say is in fact required. If we go back to that first slide I shared, 662,000, if that is going to be the cost of healthcare over the course of our life, of our retirement life, we got to make sure that we have additional insurance in place. And that's hopefully what we're going to talk through today. So before I do that, I really want to just make sure that for the folks that are on here, and I know there are a number of them. In fact, I had a meeting with one of them today, and I can see that he's in this call right now. The folks that are turning 65 soon, we're going to talk about some enrollment periods that apply to you. So we're going to talk about the initial open enrollment period, the special open enrollment period, which often looks like working beyond the age of 65, and then your annual open enrollment, which is timely to this conversation because that happens in a couple of weeks. It's from October 15th to December 7th. So first things first, with the initial open enrollment window, I want to actually make a really key distinction about the definition of retirement. So retire does not specify if you're collecting or not collecting Social Security. So a lot of people get confused by this. They go, well, John, I retired at 64, so Medicare enrollment should be automatic for me when I turn 65. And the answer to that is, well, maybe. It'll be automatic if you are already enrolled on Social Security. So if you're collecting Social Security, let's say your birthday is October 16th of this year, you turn 65, you probably already got your card, your card that shows your Part A and your Part B effective date. But for most people that aren't collecting Social Security yet or are currently working, this is their opportunity to enroll, and it will in fact require action on your behalf. So you have a 7-month window to apply and enroll in Medicare. 3 months before your birth month, and then 3 months after. And for most people, like I said, if the example I gave, I think I said like October 16th was your birthday, your coverage date would begin, if you turn 65 then, your coverage date could begin as early as October 1st. It's always the first of the month from when you apply. So a couple of tips that we typically suggest for folks is making sure that you reach out. You have the phone number here to call Social Security. You can also apply online, but doing so about 90 to 100 days before your 65th birthday, just to make sure, we're dotting the I's and crossing the T's, so to speak, and we're not behind the 8 ball, because we don't want to miss this coverage gap if this applies to us, if we're not working anymore, or we plan to go off of our company plan and on to retirement. If we miss the coverage gap, there's a sizable penalty. That penalty is 10% per year for Part B for every year that you're not enrolled. And it's 1% per month for Part D for every month you're not enrolled in a prescription plan. Now, I know you're probably thinking like, okay, man, like slow your roll. There's like A, B, C, and D, all this stuff. we're going to get there, but I wanted to make sure that we start with the dates first, just so we know, like, just a little bit of awareness of like, let's not miss this, and then be subject to a penalty. So the next one that I think is really important for folks to know about is this special open enrollment window. Now, this is for the folks that, so locally, most people here listening are local, or at least live in Florida on this call tonight. If you work for a company like Disney or a company like Lockheed Martin, you have what's called credible coverage. And so you have the opportunity to say, hey, you know what? I was planning on working until 70 and my insurance is awesome. I want to keep it. And so you can basically start collecting Part A, which is the component that for most people doesn't cost anything. And you can punt and defer the rest of your decisions until as late as whenever you retire. If you retire at 70 or 72, or anywhere between that, if you decide that you want to go off the plan. And the same can be said for your spouse. That carries over to your spouse as well. So if you're 65 and your spouse is 65, you're going to keep working until 70. You can defer and delay this decision through special open enrollment. But one quick tip I want to make sure of, as you can see here, make sure to ask your employer this question. It's a simple question to HR, somebody at your company, to say, hey, I'm turning 65. Do you guys have a coordination of benefits that you offer? Is there credible coverage? Am I allowed to make that decision? If you look at a company like CandorPath, we have a team of 6. So we would not be considered, I think 100 or above is the number, for example. So as a team of 6, if no one on our team is approaching 65, but if anyone were, they would have to go on Medicare at that point. They wouldn't be able to keep that coverage.
Hey, John. So really quick, and I forgot to mention this at the beginning, I'll be interjecting at certain points of, FAQs, frequently asked questions that may come up during these slides. So hopefully this helps. But on this slide specifically, if someone, I think you may have like touched a little bit on it, but if someone was to skip the open enrollment at 65, are they negatively impacted by?
So yeah, that's that's probably the biggest question that we get from folks is, are you like, am I allowed to do this? I get that there's a special enrollment period. And so yes, I'm allowed, but am I going to be penalized for it? The answer to that question is no. As long as you have credible coverage through your employer, for most people, what they do is they enroll in A, they defer B and everything else. They stay on their plan. And you'll see here, I've got, highlighted in red, 8 months for Part B and 63 days for Part D and 6 months for Medigap, all these different dates. It's confusing. The reality is, like, you're probably not just going to wake up one day and go, oh man, now I'm 67 and I'm ready to retire. Like the clients that we work with, we're planning towards that day. So we don't even worry about these coverage, like this 8-month window and 63-day window. Like everything starts the day that your coverage ends. Like, when you're going to retire, and let's say October 31st is when you're going to retire. So November 1st is the day that your coverage would pick up and take care of you. So you don't have a loss, you don't have a coverage gap, so to speak.
And then one more thing, if we are comparing between a company plan and Medicare at 65, how do we go about making that decision?
Oh, awesome. So it's very quantifiable. It's just honestly a numbers based. I'm a big believer, wearing my financial planner hat, that math doesn't lie. So we just compare the numbers. We look at what's the cost of your coverage right now as it exists on your employer plan, and what are some other things like the deductible and the out-of-pocket max. And we add all these numbers up and we say, well, what's it going to cost us? Which I'm going to show at the very end of this presentation, the cost of Medicare. But what's it going to cost us, and which one's more expensive? So it's a which one's maybe going to give us better coverage, and which one is the better cost point. So that's an awesome question, and we do that analysis with our clients quite often, because we have a lot of folks that turn 65 and they're like, hey, I'm not ready to retire, but I need help understanding which math makes more sense. And so actually 2 final enrollment windows to be mindful of. So there's your annual open enrollment window. That's what's coming upon us, October 15th to December 7th. Just important to know, when you're making changes in that window, it's not going to apply until January 1 of the next year. So For most people, that looks like making a change to the Medicare Advantage Part C, which I wish I was in a room because I'd like to do a show of hands, like who's heard of that? I'm sure everybody has. And your Part D prescription plan. So for most folks, that's what we're making a change during open enrollment for. And there's one final one that I want to talk about. It's called your general open enrollment window. This is if you missed your window. This, you know, I've in my entire career, I've been doing financial planning longer than I've been helping folks with Medicare. But in my entire time of helping folks with Medicare, about 13 years, I've only seen one person have the situation. He called us and he said, I just didn't think I needed to do anything. I turned 65 back in. I'm making up numbers now because I don't remember, but like I turned 65 in June. It's November. I want to go on my plan. Well, he missed his 7-month window to enroll, right? And so this general open enrollment window states that yes, you can go back and apply. You can go back on your Medicare plan, but your enrollment for doing so is Q1 of, let's say, the next year. So he found this out in November. He had to wait 2 more months to enroll, and then he had to wait 6 more months all the way until July 1st to actually have access to the plan that he enrolled in. So my general tip for this situation is just don't do this. I mean, if you're on this call, you're already proactive in nature. You're gaining information about Medicare. You're learning about all this stuff. So it's not this likely will not happen to you. But my tip is for folks that are wanting to be mindful of these dates, just don't fall in the general open enrollment window. So I'm gonna reference this slide quite a bit for everybody, and this is for me a really great visual to understand the 2 key choices you have to make when it comes to Medicare. I know that, you know, you turn the news on after this, and if you're watching, it doesn't matter if you're watching CNN or Fox News, whatever, you watch the commercials and it's Medicare commercials after Medicare commercials. You're getting tons of stuff in the mail, especially if you're approaching 65. If you're already 65, you're getting inundated with stuff in the mail. I know there are what feels like hundreds or thousands of choices and combinations, but I promise you, ultimately, it boils down to 2 decisions. Either going with original Medicare, which is the thing that the government provided to us starting back in 1965, A and B, and then adding on to that some other components like Medigap, which is also known as supplemental insurance, and a Part D plan. These are done through private insurance companies. Or Medicare Advantage Part C, which is also done through private insurance companies, but kind of wraps it all together. That's it. Like, yes, there's product companies and different things to choose from thereafter, but fundamentally, the goal I want for you tonight is, if you're thinking through this decision, is which path am I going to go? And if you've already made that decision, hopefully later on in the presentation, it'll make a little more, we'll be able to kind of solidify some facts around Medicare and give you some updates to things that are happening and coming forth in 2024. So let me talk about the actual components now that I've been talking for what feels like 10 or 15 minutes, and you're probably like, let's get into the meat of it. So you have A and B, that's original Medicare, right? Everyone here has heard me say that like 1,000 times already. Part A, if you're taking notes, which I sure hope you are, but if you're not, Raina can send you the recorded video of this later. But if you're taking notes, I want you to write Part A, and right next to Part A, I want you to write hospital and $0 per month. So for most working Americans, if you paid into your Social Security and Medicare tax for at least 10 years, you generally don't have a premium associated with Part A. So that's not something that you need to be concerned with. Now there's that's your hospital coverage, that's your skilled nursing coverage, your hospital care, and there's a deductible. It's a $1,600 per benefit period. Now what happens is you pay 16, you take an ER visit, you have an ER visit, you pay $1,600, and then you have in the hospital for the first 60 days a $0 per benefit daily copay. Day 61 through 90, it's $400. Day 91 through 150, it's $800. And after that, all those costs are on you. And by the way, that $800 per day amount, that is a lifetime reserve number. So if you're in the hospital for 150 days and 5 years later you go to the hospital again, your coverage ends at day 90. It ends at day 90 with this $400 per benefit per day. And you can start to see, like, if all we're given is Part A, and I haven't even talked about Part B yet, but you can start to see like, whoa, that can really rack up if I'm going to have to pay this deductible when I go to the hospital, and then I have this daily copay, and if I'm in there for an extended period of time. And the same thing goes for long-term care, which is why I emphasized at the very beginning that long-term care is not a suitable option for Medicare or Medicare. Reverse that, is not a suitable option as long-term care, because after day 100, you are on the hook for all of the costs for a long-term care facility.
John, really quick, so you
Yeah,
have it underlined for us. Can you elaborate a little bit on what per benefit period means?
totally. So for most of us listening to this, we're used to healthcare coverage that has, let's say, a deductible for the year. So the plan starts January 1, December 31st. You hit your deductible in April, and you're good the rest of the year. With your Part A, your hospital insurance, that is not the case. Your per benefit period is every 90 days. So if you go to the hospital in January, and you go to the hospital again in May, and you go to the hospital again in October, you're going to pay that deductible each time you go to the hospital. So that's a really important distinction to note. I think most people just assume like, oh, that's cool, I can do that, $1,600 for the year, I can escrow for that. That's not necessarily the case if you're very ill and you're having frequent hospital visits. Per benefit is every 90 days. That's an awesome question. So on your notes that you're taking, you have Part A, $0 hospital. I want you to write Part B, doctor's insurance, $164.90 per month. So for most folks, that's the number for 2023. For most folks, it's $164.90 per month. And honestly, it's really straightforward. It's your doctor's insurance. It's also outpatient procedures. It's blood work. It's home health visits. You're going to have a deductible. This is annual. This is not a per benefit period, every 90-day renews situation, of $226. And then you have a co-insurance of 80/20. 80% is covered by Medicare, 20% is you. But there's notice here. There's no out-of-pocket max. So that number could continue to roll up on you. And one other thing I just want to mention, every year when I do this presentation, I have a lot of people say, like, what's the number for 2024? And we always try to time it right before open enrollment. And we never know. In fact, like, I don't even know if the government knows what like, this is the projected number it's supposed to be. It's supposed to go up about $10 per month next year. And they typically don't announce it until like the middle part of December. So we won't know what this number is for sure. So don't quote me on it, but this is what the number is projected to increase to in the year 2024. So the next thing that I think I'm probably, if I could see faces, which I can't, but if I could see faces, I might be seeing some sentiment in the room of like, wait a minute, I pay more than $164.90. I pay way more than that, actually. What gives? Why? Well, there's this really important caveat with Part B called IRMA, Income Related Monthly Adjustment Amount. The mouthful. I got it out. I was afraid I was going to butcher that one, Raina. I didn't, though. I'm proud. And so this is, it has very much to do with how much you earn. It honestly, it's a tax. It's like a tax. It comes through as a surcharge to your premium. But it's like a tax. So I would encourage you, as you're looking at this and maybe, screenshotting this, taking a photo of this here, think about your situation. Are you married, filing jointly? Do you file single? And then maybe go to the corresponding number. So let's say you're married, filing jointly, and you, as a couple, on your tax return, you made $200,000. Now, notice a couple important things. It says MAGI, that stands for Modified Adjusted Gross Income. So that's like your tippy top number on your tax return. And also it adds back tax exempt interest. So if you have like municipal bonds in your portfolio, that number gets, and that generates interest, that gets added to this number. So let's say your number is $200,000. Well, if you made $200,000, you're not paying $164.90 per person. You're paying $230.80 per person with the surcharge, and another $12.20 on top of that for your Part D plan per person per month. And you can kind of see as this number goes, this is not a fun chart to look at. The further down this chart you go, the higher the number. Now, another thing you might be looking at this wondering, I hope you are, if you saw this at the top, it says 2023 brackets. But down here, it says in the tax year 2021. And I was hoping somebody in the chat would be like, John, that's a typo. You made a typo. It's actually not. And if you think about it, it kind of logically makes sense. So the IRS wants to fact check you. They want to know what your income actually is. And so when you go on Medicare, they're looking at, let's say you go on Medicare in February of this year, you turn 65. Well, you haven't even filed your tax return yet. And I would argue that most Americans don't file, most of them file an extension and maybe don't even file until like September or October. So they don't have any data for you yet on 2022. They go back another year further and they look at your 2021 number to determine that for the year that we're in. So it's a 2-year look back. And I think the biggest thing that I want to talk about in that 2-year look back for the folks that are approaching 65 or are approaching that special enrollment window, maybe they're 68 and they're getting ready to retire. It feels pretty unfair, doesn't it? Like, maybe you had an awesome year, which likely your final years going into before retirement are probably your peak earning years. And let's say you made, over $250,000 in that year, but you retired and you went on Medicare. Feels awfully frustrating that you have to pay a surcharge for a number that you no longer earn, a number that you earned 2 years ago. Well, there's a form called the SSA 44. And if you take your phone and you scan this picture right here on the photos, this link will send you directly to Social Security's website and directly to this form. This form allows you to appeal the decision from Social Security when they send you that nasty letter that says, we saw that you applied for Medicare. Congratulations. By the way, we also saw that you made $480,000 last year. So we're charging you $428 a month for your premium. You can fill this form out. And one of the main qualifying events that we see with most of our clients is that it's a qualifying life event is retirement. I made a number. I no longer make that number. In retirement, my income is maybe below 194 as a couple married filing jointly. And so I shouldn't be assessed this premium surcharge. And I know you're thinking, great, that's the government. It's going to take 6 months and they'll never reply. Interestingly, they're actually very on top of this. We have done this probably, I'd say more than a dozen times for our clients over just the last couple of years. And they're very quick and very responsive to say, yep, okay, we got that. That's fine. We'll take it off. And there's some other qualifying life events too. Loss of a spouse, loss of rental income producing property. So there's other stipulations around how you can maybe reduce this thing. And honestly, the government's not advertising this form. I mean, it's buried on their website for a reason. I don't think they want people to necessarily know that you can appeal this, but you can. That's a really important thing for people to know.
So really fast, putting on your financial planner hat. For those of us who fall, or the people that fall into the higher brackets here, are there strategies for them to be able to help reduce their IRMAA surcharge?
Awesome question. Of course. And I think you're right. Like wearing that financial planning hat, guys, joining this call, like that's fundamentally where all this began for us. I'm a CFP by trade, certified financial planner. We help folks navigate retirement. And I think you're probably wondering, like, what's the CFP even talking about all this stuff for? And I think, honestly, it's because of strategies like what Raina was alluding to, where there's a number of ways we can work together. We work together as a team, which if I just back up for a moment, I didn't get a chance to explain this. We work very much, we call it an ensemble approach, but my business partner, Matt, that's not able to join us on this call tonight, he's an enrolled agent with the IRS. He does about 160 tax returns a year for all of the clients that we serve. And we do that because there's just an intimate knowledge and understanding of what's going on the investment side, what's going on with their tax situation, and obviously here in this context, what's happening with Social Security and with Medicare. So there's a number of strategies here. And if any of these are appealing to you or you're reading this, you're like, wow, that might apply to me, certainly feel free to reach out. One that I want to point to here is right in the middle. I have QCDs. So qualified charitable distributions. Now, everyone or most people joining this call are very familiar with your required minimum distribution. The age used to be 70 and a half. Then they moved it to 72. And I think they're moving the yardstick again based on some recent legislation. But basically what that means is if Sally has $500,000 in an IRA and a 401k, the IRS comes to her and says, hey, Sally, you turned 72. We don't care what you do with the 500,000. You can invest it however you want to. But we're going to make you take a percentage of it out. We're going to make you take some of that money out of that so that we can tax you. We want something to flow through on your tax return. So this is a really common problem for the retirees we work with, where between pensions, social securities, distributions, dividends, and then their RMD, it puts them over a threshold. Well, if the same example I just gave you with Sally, if Sally is giving to her church every Sunday, if she's writing a check and putting it in the basket and passing it on, we have a conversation with her and we say, well, hey, you're basically taking the money from your RMD, you're receiving it, and then you're giving it to an institution, a church, a 501c3, or what have you. Why don't we do this qualified charitable distribution, remove you as the middleman person in that, and give it directly from your account to the organization? And in doing so, that does not show up at all on your tax return. Now, there's like several steps to jump through. It's a very complex strategy, but it's important to know about, because if you're giving inclined anyway, and you're writing a check to organizations to give at the end of each year or to your church, what have you, the QCD is a very, very viable option for folks that are kind of permanently year by year in this Medicare IRMA surcharge situation. So awesome question, Raina.
John, really, really fast. So Mike had asked in the chat, and I feel like it's pretty relevant. So he asked, do these numbers go up each year? And I think he's talking about the surcharges.
Yep. Thanks for asking that, Mike. They do. So best example I could give would be like married filing single. I'm recalling from memory, but last year the year before it was 94,000, and now it's 97,000. So they are tied to an inflationary number, and they do increase each year. Awesome question. So fundamentally, what I've broken down so far, I know I went off on a tangent with the IRMA thing, but I thought it was important, is Part A is your hospital coverage. Part B is your doctor coverage. This is what's known as original Medicare. This is what the government gives us for healthcare after the age of 65. Now, again, I'm going to remind you, and I'm going to recall this slide a few times because I really like it. Now we're going to dive into what are some of the things that we wrap around that? What's this whole deal with Medigap and supplement insurance and Medicare Advantage Part C? And so I'll start with Medigap. It's also known as supplement insurance. It's if you hear people using that vernacular, it's the same exact thing. And it does kind of what it sounds like it does. It fills the gaps that Medicare doesn't cover. So it's a private policy. It's done through a private insurance company, and there's a ton of them out there that do this. And they basically help offset the things that Medicare will not cover. Now, there is an additional premium to do that. And unfortunately, your prescription coverage is not included in that. That is a separate thing that's known as Part D, which I'll probably spend the least amount of time talking about, but it's also an important component as well. And the plans can just vary, in cost and in coverage, which the next slide that I'm going to share will explain that. But I think we have some important info on HSAs we want to touch on here.
Yeah, so in your quick tip at the bottom, you say that you cannot use HSA funds to pay for Medigap premiums. I just want to touch on the things that we can use HSA funds for. So sorry in advance, this is a mouthful if you're trying to write this down. But the qualified Medicare expenses that HSA funds can cover are Medicare Part B, Part D, Medicare Advantage plan premiums, deductibles, co-pays, and co-insurance. So I think I got everything there, John, but
nailed it. Yeah. And putting that CFP hat on again, December of 2003 was when legislation was passed for HSAs. And so I would say right now, like we have a lot of retirees that are retiring with HSA money. We're getting this question a lot. What do I do with the money? Like I funded all this HSA, it grew. I didn't need to use it. Thank God, knock on wood, I was healthy. But now I've got a bunch of money in an HSA account. What do I do with it? There are a ton of outs to be able to use that with tax preferential treatment. The only one here is that you can't pay for your Medigap premiums. But I would encourage, especially friends and family of anyone that's listening, if you have folks that are, let's say, younger, like in their 50s, late 50s, early 60s, and they're like thinking about this stuff, find a way to max fund that HSA through work. It is an incredible vehicle. It's one of the only things in the US tax code where the government lets us put money in, get a tax deduction today, get tax deferred growth, and then take it out tax free. And back to that first slide of 660 whatever thousand in retirement of healthcare costs, we're going to use those HSA dollars somewhere. So it's a really important one, and that's why that's there. Because I mean, we could probably do a whole presentation on just HSAs, honestly. But going back to the supplement stuff for a moment, so you'll see this overwhelming chart that for folks that have joined this one before, I've spent a lot of time on this. There are 10 different coverage options with supplement or Medigap insurance. And to just make it more confusing, because why not? There's a supplement plan A and plan B, not to be confused with parts A and parts B or C or D. And so you can kind of go down this list, A all the way through N. So there's about 10 different options available to you. Now, one thing is very important to know for most people that are already 65 and have experienced this decision, no doubt you've heard of Plan F. That was kind of like the Cadillac plan that everybody, if they wanted comprehensive coverage and they didn't want to worry about this stuff, they went with Plan F. The government essentially did away with that in 2020. So you were grandfathered in. So if you already had the plan, you could stay on the plan. But after 2020, Plan G kind of became the new Plan F. Like that was the more, if we're going for the most comprehensive coverage, Plan G is a very popular one. And there's really only one fundamental difference. And it's that Plan G doesn't cover your Part B deductible. Plan F did. Your Part B deductible this year was $226. So what that actually looks like is you go to the doctor, you have maybe 2 or 3 visits, you hit that $226, and then the plan covers everything else. And what's interesting, as long as it's medically necessary, but what's interesting is when in the year that they did away with F, I always evaluate it because people would ask me like, should I go with F or should I go with G? And for years, the cost differential on the premium over the course of the year was literally it was like $200. It was the Part B premium. So it was a little bit of like trickery of math. It's like, well, we saved a little money on premium. We saved a couple $100 with going on the Plan G, but it doesn't cover our deductible, which we have to pay out when we go to the doctor. So it was kind of 6 in one, half a dozen the other. And another very popular supplement plan for folks is known as Plan N. Now, if you look at Plan N and you look at Plan G, you'll kind of notice pretty much same things down the line, except this box is not checked. It's known as Part B excess charge. Now we're getting into risk profile. How comfortable are you with taking risk? So we talk to clients about this all the time. If you research Part B excess charge, there's a lot of differing information out there. To define it as simply as I can, let's say you have a knee surgery, it's $5,000. Or your doctor and anesthesiologist and all that bill $5,000. Medicare says the last surgery is $3,000. Well, now we got an excess charge. We got a difference of $2,000. On Plan G, you don't have to worry about that. On Plan N and some of these other ones, you do have to worry about that. The question that I'm posing, which I'm not going to answer because I don't know the reality of it, but there's a lot of literature out there, if you research it, that suggests, is Part B excess charge actually a thing? And I think the supporting argument for that is if the doctors that you're going to, the physicians, the surgeons, whatever, if they accept Medicare, they're working within the Medicare pricing schedules. So likely it may not be as big of an issue. And so Plan N is probably the next most in popularity. And you save a little bit of money by going on a plan that does not cover Part B excess charge. So no doubt a lot of information here, but those are some of the highlights when it comes to supplement. So now what I really want to get into is just comparing and contrasting this thing Medicare called Medicare Advantage and supplement. Before I do that, a couple key terms to keep in mind, which no doubt all of you are probably familiar with: premium, coinsurance, copay, deductibles. That is the land that you live in when you're on a Medicare Advantage plan. It's going to operate very differently from everything I just explained with supplement, where it's like you have a surgery, like supplement is basically meant to cover all the things. If you go with like a Plan G, let's say, that A and B don't cover. Part C, Medicare, also known as Medicare Advantage, is at minimum, it has to administer and adhere to what A and B cover. So at minimum, it has to do that. But it does one better than that, which it also has an out-of-pocket maximum. Now, these range, but legally mandated by the government, the highest out-of-pocket max that are allowable in Medicare Advantage this year is $8,300. So these are offered by private insurance companies. They kind of say, hey, we're going to cover A and B, but you're going to have co-insurances, you're going to have deductibles, you're going to have co-pays when you go to the doctor or the hospital. And ultimately, if you have you'll save some money, which I'm going to show the price change differentials here in a moment. So you'll save some money by going on Medicare Advantage. But in doing so, you might have to outlay some money if you have a relatively unhealthy year. And the most that you'll have to outlay in that year is $8,300. That's the out-of-pocket maximum. And then a little nod to Part D prescription plans. So these are the national average for these is going from like 32 to 34 bucks a month. That's the national average. I have clients that kind of vary all over the place in this. And honestly, the reason I spend the least amount of time here is it's just insanely specific to your situation. So the drugs that you take, if you're working with a sales agent for Medicare, that's going to help you with this stuff, or if you want us to do like a quick RX, we have a search tool for this too. We take the client's age, all the different prescriptions that they take and the dosages, and it spits out to us out of the dozens and dozens of options in our zip code, which one is the best plan for the drugs that we take. It's insanely personal to you and your situation. And for most people, if you go the supplement route, you get a separate standalone Part D. But if you go the Medicare Advantage route, it's all combined inside of that. So hopefully that makes sense. Because this next slide's confusing, so I'm going to spend a little more time on this one. So for years, I hated talking about this. It was called the donut hole. And it was really confusing. And I would find that it would take the majority of our presentation just talking about this. And so thankfully, the government listened to my strongly worded letters that I wrote them, and they said, finally, we'll close the donut hole. I don't know that that's what happened, but you get the point. They have done that. And so here's kind of how it functionally works. So let's pretend, for most people, if you're taking generic drugs, you're going to have a plan. I'm giving you general numbers. So, but the reality is you're going to have a plan that maybe costs 12 to 30 bucks a month, and you're going to pay $0 copays to $10 or $12 copays for your drugs. If you take generic, like tier 1 drugs, if you're in a situation where there's chemo treatments, there's really expensive specialty high tier prescription drugs that you take, then this slide matters for you, and you should take a picture of this slide. So this year we have a $500 deductible. So, let's say you have a $1,000 drug that you need to fill. The first 500 bucks you're paying, like you're paying $500 for that. After 500, and actually, but these next two charts here really, what is impactful to you is between $500 to $11,200. You're now on the hook for 25% of it. So if it's $1,000 prescription per month to fill that, you're paying $250 of that $1,000. Now, what you'll notice here, the difference is Part D, your plan that you have through your private insurance, through your provider, is covering 3/4 of that. After a certain number, 4,600, then they cover only 5. And actually, interestingly, and this is kind of how they close the whole like donut whole situation, the drug manufacturer covers a big portion of that. So it really doesn't change for you until we get to catastrophic. At $11,200 in total outlay of cost for prescription drugs, you now then only pay 5% of that for the rest of the year. So this is January 1 to December 31st. What's changing in 2024 is that this 5% is going to 0. That's the only fundamental change. Maybe there's some other levers to pull here, but functionally that's the biggest change and announcement that we've heard so far on Part D, is that this little sliver after 11,002 is going from 5 to 0%. So important to know, especially if you have a very unique drug coverage situation. So cost comparison, like drum roll. So the first chart that I want to show you, this is what I started with. So parts A and B, your supplement plan, and a Part D plan. Now, of course, these numbers vary. Like if you fall in the IRMA surcharge number, you're not paying $164.90. You saw from that previous grid, you're paying a higher number. But we're going to say, we're going to start at $164.90. We have a Medigap plan, and I'm just using kind of averages, but I am trying to quote for somebody that's like 65 coming into this, and they're looking at like a Plan G or a Plan N type thing. We're about $180, and then the national average for Part D, you're at about $380 per month per person. If we go over to the Medicare Advantage route, we still, and this is a huge misconception that I want to squash. I have actually been to Medicare presentations, which I stick out like a sore thumb because, like, I obviously like I'm getting a lot of grays, which I think you can see, but I don't look 65. So I've been to presentations where like, yeah, you go on this plan and it doesn't cost you anything. Well, that's not really true. You still have to pay your Part B premium. Now, Part C for a lot of folks might be $0. I'm quoting the national average, which is $17.60. Despite that, that's not a big number. What you notice here, though, at the very bottom, is there's about a $200 per month per person differential on these plans. So hopefully, and I did this at the end because I didn't want to lead with numbers to try to like guide somebody in a direction. I want to just kind of like fundamentally explain the way the coverages work. But you're probably seeing this going, okay, I get it. There's more like one is more of like a, pay into your premium, like pay now and worry less about your coverage later, or save some money, but potentially have some issues with Medicare Advantage as far as like out-of-pocket maxes and costs that you would incur. So how do we make the decision? It's hard. We certainly help clients navigate that when we meet with them one-on-one, but ultimately, and especially in this conversation, we're really just trying to give you a lay of the land. So first thing that I want to just jump right out with and lead with is that at the very bottom, you'll notice under original Medicare, Medigap, and Part D, you'll see here I have guarantee issue. So when special enrollment window opens or your open enrollment window at 65 begins, that's your opportunity. That this is like you see the commercials and they're like, make this decision now and do it right or forever be, it's an irrevocable choice. And like in some regard, it's not, which we'll talk about in a second. But in some regards, like those two paths that I talked about of taking either original Medicare and Medigap or Advantage, that kind of is. Because what'll happen is, so this is guarantee issued onset. So if I'm making up a scenario, but if you're cancer risk, if you're diabetic, if you have bad family genetics, high blood pressure, you just like things medically and health wise don't look great for you. They can't rate you. They can't decline you. They can't charge you more than they're going to charge somebody else that's seemingly healthy. They have to accept you on this more comprehensive plan. They have to. Now, let's say 3 years go by, you go on Medicare Advantage, and you say, oh gosh, you know what? Some things have come up. Actually, I want to flip back over and go on this plan. It's too late. I say it's too late. It might not be, but usually it's driven by a medical decision. Like, oh my gosh, I just had a heart attack. Now I want to go on the more comprehensive plan, and they're going to decline you because they're going to underwrite you and they're going to say, sorry, no, you missed your window to go on this plan. Now, I sound like I'm really like a big advocate for this plan right now. And maybe I am, but also that's not the goal for this. I'm just trying to emphasize the importance of the decision. That's what they're talking about when you see those commercials and they're like, make this decision right or forever hold your peace. So with original Medicare and Medigap, you have no out-of-pocket maxes. You're not working within a network, which I don't know if I failed to emphasize that. So if the doctor accepts Medicare, they accept your supplement plan. That's it. Like, it doesn't matter who the provider is. It could be United, Cigna, Aetna, Blue Cross. Like, it doesn't matter. If they accept Medicare, they accept your supplement plan. And so it's much more straightforward. And I'll explain some qualitative life factors in a moment. But for example, I have a client that lives here locally, wants to go to Moffitt Cancer Treatment Center in Tampa. And so for him, the choice became a little bit easier to just go on Medigap because of some health issues, because he wanted to be able to have access to medical providers that were otherwise out of range because they were out of network in more of a regional Medicare Advantage plan. So again, with Medicare Advantage, you're saving money, but you're going to have co-pays, co-insurance, deductibles, and HMOs. So why would somebody choose? Well, actually, Raina, did you have a question before I jump to the next slide? Because I'm getting excited. I know we're about to wrap, but I'm going fast.
Yeah, I jumped in at one point and then I let you kind of finish your thing. But so if someone was to select the Medicare Advantage and then decide later on that they don't like it, can they make a change later on?
So, in the example I gave where I said 3 years later, and then they decided to go, the answer was no. But there is this thing called trial right. And candidly, the best way I like to describe it, it's like pulling the e-brake. It's within 12 months. So let's say open enrollment happens. You say, hey, I want to go on a Medicare Advantage plan. And within that 12-month window, you want to make a change and go on to a supplement plan. You can do that, and you can do it without these underwriting issues that I just shared. There's several hoops you need to jump through. And I view trial right as kind of like we're pulling the e-brake. Like this was, I don't think we need to get to that point in the decision if before you make the decision, we weigh the pros and cons and we have a really good conversation around like what makes the most sense. And I think that kind of leads into this slide of these quantitative, very numbers-based choices and qualitative. So the example I shared of that client that has some health issues, personal health was very important to them. But I have clients that go, gosh, I mean, I have one client in particular that's 65 and he looks 52. Like, and he's like, I'm healthy. I don't need to go on the more comprehensive plan. And also, what's interesting, what also connects to that is that his risk profile is different. He's more of a risk taker. We're talking a portfolio that's like 90 to 100% equity. So like even that keeps me awake at night sometimes. But that person's willing to accept that risk of like, you know what, I'll save some money on my monthly premium. I'll escrow it. I'll put it aside. It's not a big deal. I'll make sure I have enough that if I hit this annual out-of-pocket max, I can cover that. And so maybe Medicare Advantage in that person's case makes a lot more sense. But somebody that has health issues already before they even turn 65 might lean a different way. Also, like I said, ease of use and convenience, being able to say, hey, I just want to go, like, as long as the doctor accepts Medicare, I don't have to go like within an HMO, like most of us are used to on healthcare plans where you got to go to your primary care to get a specialist referral. We don't have to do that. And if I don't want to do that, maybe I want to go on more of a comprehensive supplement plan. So there's an array of things that go into this decision for people, and it makes it hard when there's qualitative choices. Like we always, this is kind of like a morbid joke, but like we always, talk to clients like, if we knew the day that the good Lord called us home, that would be like we could plan every dollar up until that last day so that it goes to zero on that day, but we don't know what that looks like. And so for our clients, we're trying to create sustainability and like we don't want this roller coaster ride in your portfolio. Most people don't in retirement. You want like a nice, smooth, steady up, trend on the chart line. Well, the same thing goes for expenses for a lot of people. If you're risk averse, you might want to make sure that you're able to manage and control your expenses. And if it's budgetary friendly and you can afford the premiums, maybe you want a smoother, steady trend of your expenses, not this, great, I saved some money this year, but then I had to outlay $8,300 next year because I hit my deductible. So, or my out-of-pocket max. So there's an array of factors. And honestly, if I just bring it all back to the very first point I made when we started talking 13 years ago, when I sat with that client, I listened to her get pitched and sold and told what she needed. That's when I said, like, I'm going to get my licensing for this. I'm going to do CE every year. I want to make sure that we know this and we can educate our clients on that. So it's really, the goal tonight is not to give you the answer on what you should do, but just to empower you with the tools necessary to at least give you a better grasp on all this and help you make a better decision. Point that Medicare guide. So if you go to canterpath.com/Medicare, we have a PDF download that really, like, now that you've experienced this conversation, for the folks that have this is your first time, it can be a really good tool to just look at those important dates, the A's, B's, C's, and D's, kind of like a summary version now that you have a deeper dive on this. So there's a PDF download that you can go to and grab, and some other resources on there as well. So I'll answer only the couple of questions that we had. The first one, January, I will be eligible for Medicare through disability. I'm 56 years old and I have I have no clue where to start. So this is one of those situations, actually. If you go to canterpath.com/Medicare, there's actually a link to schedule time with me. I can go through and explain that a little more specifically, but the beauty of this is actually disability is not that different than as if you were turning 65. So it's irrelevant that you're 56. As long as you're eligible for Medicare, you can do all of the same things that we talked through. It's just that your start date began on a different date. That's essentially the way that works. And then one more question. I think I might have ultimately answered this somewhere throughout it, but the average cost for like a Plan G coverage gap, that supplement plan, it does range based on male and female and date of birth, but it's somewhere around 180 to 190 per month. And so I can look up that more specifically for you if we need to. So I think that answers all of the questions. Thank you guys all for joining Raina and I on this Medicare workshop that we get an opportunity to do every year. Thank you to Oasis for opening this up to your community of folks. We love spreading good information on this. So we appreciate our clients and everybody that joined us. We'll see you guys.